Good morning to all. Good afternoon to all. Thank you so much, Professor, for your introduction. I'm a research assistant, have been working at Epicentre office in Cameroon for 5 years. It's an honor for me to present you with this presentation on the validation of a clinical score for the diagnosis of Mycobacterium ulcerans. Buruli ulcer infection is a tropical disease that you find in endemic areas. Its manifestation are nodules, plaque, and the most severe form being skin ulcers. Oral route treatment combines rifampicin and clarithromycin. It takes 56 days, and the diagnostic is done by a PCR microscopy and culture. It's quite limited, though, those exploration means, so usually it's just the clinician that makes the diagnosis. We tried to put together a rapid diagnostic test, and between 2013 and 18, there was no upgrade or no improvement in the diagnostic of Buruli ulcer. That's why we set up this study so as to inform the diagnostic policy and also to inform a better management of patients with Buruli ulcer. Between January 18 through October 19, we carried out a prospective observational cohort study with quantitative components on the evaluation of the clinical and qualitative score and its acceptance. The study took place in the health districts of Akonolinga and Ayos in the Center region and in the health district of Bankim in Adamawa. The sample size required was 138 samples PCR positive and 138 PCR negative samples. To reach our objectives, we've enrolled the patients with ulcerous skin lesions who agreed to participate in the study. We made a presumptive diagnostic before applying the score to the patient. Then a nurse would make a swab sampling and would send that to the Pasteur Center in the capital city of Yaoundé. To assess the acceptability of the score, we had focus groups, group discussions, and individual interviews. We talked with the patients, with the traditional healers, and with the health staff. Please note that the Buruli ulcer in rural areas is considered as a mystical disease, which is why the patients go and see traditional healers first. There are some criteria, the odor, the pain, the size of the wound. We give points, and you get the score this way. The score can be divided in 3 categories. Low probability score when it's below or equal to 0. The score algorithm considers it's not Buruli ulcer. Then intermediate probability score from 1 to 4. It may be Buruli ulcer, but it calls for confirmation with PCR analysis. And finally, a high probability score when it's equal or above 5. The algorithm would then consider it is Buruli ulcer. To evaluate the score performance against PCR, we evaluated its sensitivity, its specificity, and its predictive values, and we obtained the following results. We enrolled 340 patients out of 362, so 22 were excluded from the study. The patients were aged from 1 to 85 years old, mean age 27. Most of them were men. Among the 340 patients, we had a total of 392 lesions. 87% of the patients had ulcerous cutaneous lesions. Out of the 392 lesions, only 364 were obtained with PCR, and among those, 139, that is 38%, were positive to Buruli ulcer, and 225 were negative. Psychological assessment was carried out, showing that 22% of the patients evaluated had psychological distress, calling for a proper management. Now, it's important to note that the score was not used as a tool for decision-making for managing the patient during the study. So we didn't use the score to make decisions during the study. Only the decision made by the doctor and the PCR results were taken into account to decide to place the patient under treatment. But had we taken into account the score algorithm, we would have had the following results. We would have applied the score to 313. 156 would have had a low probability score, would have been considered as negative for Buruli Ulcer. 103 would have had an intermediate probability score. According to the algorithm, they would have been placed on treatment, waiting for the PCR results. And finally, 54 would have had a high probability score, would have been put on treatment directly without being sampled for PCR analysis. And after the PCR results, we would have had 99 patients in total that would have been treated for Buruli ulcer and 214 that would have been treated for other infections. The algorithm of the score shows a sensitivity of 69% and specificity of 94%. There is also a pretty good correlation between the use of the score among doctors and nurses when they're familiar with the scoring. The clinician's judgment shows that she can diagnose 53% of the positive cases for Buruli ulcer. But also, because of his judgment, he placed 47% of the patients who didn't have the disease, according to PCR, were placed on treatment. So the judgment of the clinician has a sensitivity of 52.6 and specificity of 88.5, which is lower than the score algorithm. The diagnostic clinical score of Buruli ulcer is well accepted by most patients, traditional healers, and health staff. And it's important that this scoring is made available to all hospitals because we can diagnose the patients earlier. It's well accepted by doctors and nurses. We need this tool to be decentralized for the management of ulcerated forms of BU, Buruli ulcer. The score doesn't replace the full PCR test. There is always a risk of getting false negatives. The samples taken also contribute to the development of rapid diagnosis tests in partnership with the Swiss Tropical Health Institute. And the score performance meets the guidelines of WHO with the predictive positive value above 70%. It should be integrated in national health policies, and discussions are underway with the Ministry of Health and WHO. This is a picture in one health district that participated in the study. We would like to thank all our partners, Sirens, Epicentre, MSF Swiss, that supported us, the Pasteur Center in Cameroon, and Active and AFPA associations, and those who helped us in the psychological evaluation of the patients.